is a symbol of brightness and prosperity. The Indian culture dictates that the traditional lamp be lighted before any auspicious ceremony. So, I invite the dignitaries to formally inaugurate the function by lighting the lamp. Dr. B. Nagarajan, President, Association of Veterinary Dermatology, India.
We hope to learn a lot from their lectures. Dr. Chiara Noli, DVM, Diplomate and President of the European College of Veterinary Dermatology, graduated in veterinary medicine from the University of Milan, Italy in 1990. After a residency at the University of Utrecht, Holland, she obtained the European Diploma in Veterinary Dermatology in 1996. Since then, she works as a referral dermatologist and dermatopathologist in northern Italy. Dr. Noli was president and founder member of the Italian Society of Veterinary Dermatology, president of the European Society of Veterinary Dermatology, and board member of the International Society of Veterinary Dermatopathology and of the World Association of Veterinary Dermatology. She is currently president of the European College of Veterinary Dermatology and member of the Global Veterinary Dermatology Education Group. Dr. Noli is author of more than 100 articles in Italian and international journals, of 9 book chapters and 3 veterinary dermatology textbooks, and co-editor of the books Veterinary Allergy, published by Wiley in 2014, and Feline Dermatology, published by Springer in 2020. She has given several hundred lectures in Italy and in other countries of 4 continents. Her main interests are feline allergy, feline food hypersensitivity, and quality of life assessment in veterinary dermatology. I welcome you to this occasion, ma'am. I invite Dr. B. Nagarajan, President, Association of Veterinary Dermatology, India, to honor Dr. Chiara Noli with the garland and shawl. Thank you, sir. Thank you, ma'am. Dr. Elisa Maina, DMV, Diplomate, European College of Veterinary Dermatology, European Specialist Veterinary Dermatology, and PhD in Immunology, graduated in 2008 at the Faculty of Veterinary Medicine of Milan, Italy. She followed the course of dermatology of the European School of Advanced Veterinary Studies in Austria in 2010. In the same year, she completed a dermatology externship at the College of Veterinary Medicine, University of Florida. After a residency in Italy, she obtained the European Diploma in Veterinary Dermatology in 2015. In 2012, she won the scholarship Ghent University Special Research Fund for a PhD in dog food allergy, and obtained the PhD in Immunology from the Faculty of Veterinary Medicine of Ghent, Belgium. In 2018, she obtained the title of Italian Specialist in Internal Medicine in the same year. Dr. Maina is a member of the Credentials Committee of the ICVD College and a member of the Scientific Organizing Committee of the European Dermatology Congresses since 2018. Chair of Credentials Committee of the ICVD College from 2021. She has given several lectures, is author of articles in Italian international journals, and currently she is seeing referral cases in Switzerland. On behalf of everyone, I welcome you to this occasion, ma'am. I request Dr. Jairam Ramani, Secretary of Association of Veterinary Dermatology, India, to honor Dr. Elisa Maina with the garland and shawl.
Thank you, sir. Thank you, ma'am. Now, I invite Dr. S. Venkateswaran, Vice President, Association of Veterinary Dermatology, India, to deliver the welcome address. Dr. Venkateswaran has over 30 years of experience in companion animal practice, with a special interest in small animal dermatology. He is the co-founder of Cotton City Pets Polyclinic at Coimbatore. He has documented life cycles of different parasites of dermatological importance. Sir, I invite you to deliver the welcome address.
Good evening, ladies and gentlemen, my veterinary brothers and sisters. I welcome you all to the second Indian Veterinary Congress organized by Association of Veterinary Dermatology India to Cochin. Cochin was preferred because this is in God's own country and wonderful people, wonderful vets who have helped us also here. And I welcome Association of Veterinary Dermatology India welcomes proudly Dr. Chiara Noli. We are indebted to Chiara Noli because he was in the west of Italy last week and traveled back, and now she is in the east of Italy. With lots of travel and other things, she is committed to give us a good lecture. I welcome you, Dr. Chiara Noli. I welcome Dr. Elisa Maina. Dr. Elisa Maina, so exuberating with the joy. The moment she heard that she is going to come to India, and that to God's own country. And I'm proud that she has left her 3-year-old kid there to give us a good lecture. I welcome you, Elisa Maina. Definitely, both Dr. Chiara Noli and Elisa Maina going to give a good partnership and going to give a long and a better innings for us in the next 3 days. Next, I welcome all the veterinarians from across the country, from Jammu to Trivandrum and Kanyakumari, and from east, that is Nagaland to Surat and in Gujarat also. So we are proud that Association of Veterinary Dermatology really has gained the name IAVD India. I welcome all the sponsors who have generously helped us and to come and grace the occasion. I welcome you all the sponsors. And finally, I welcome one and all. Thank you.
Thank you, sir. Next, I invite Dr. Jairam Ramani, General Secretary, IAVD, and CPD Director of FASAVA Board to deliver the Secretary report.
Respected speakers, Chiara Noli, Elisa Maina, my President, Dr. Nagarajan sir, my entire team of AVD. I am here to present the report, but before all of that, I want everybody to acknowledge Dr. Nagarajan's efforts. This is almost entirely his baby. Thank you, sir. Please stand. It would not have been possible without him. Single-handed. It's all his, so whatever he says. So I welcome each and every one of you. The Association of Veterinary Dermatology started as a little idea in somebody's brain. Big brain is there, small brain, many small brains were there. So, but to see it fruitful within 3 years, I think is God's blessing. So what I will give you a small rundown on what we did over the last 2 years. So we decided to hold ICVD1 in Madras in association with Tanuvas, and the best part was we got recognized by the World Association of Veterinary Dermatology, which is a big achievement, and I thank everybody. So the hard task starts now that we have been given 5 years to prove our worth before our affiliation becomes final. So I request everybody to make it a point to attend every ICVD. So ICVD was a hybrid conference because it was during the COVID period. So a lot of foreign speakers couldn't attend. But we had Dr. Sue Patterson, Dr. Kochi, and Dr. Ronnie Kaufman, Dr. Han, all delivered lectures through Zoom. And Ronnie Kaufman came by herself, Dr. Han, Hock Siu, and Dr. Alberto from Mexico gave lectures on Zoom. We had a number of Indian speakers who delivered lectures. And in the process, since the inception, we have delivered almost 27 webinars in various aspects of dermatology. In ICVD2, we had 4 research teams covering canine atopy, dermatophytosis, mange, and a wide range of skin conditions. Leading speakers over the last 1 year have conducted lectures. We had Sumati ma'am speak on pruritus, we had Survi Gupta speaking on canine pyoderma, we had Meera Sakre speaking on lumpy skin disease, which affected a large number of large animal cattle, and a lot of veterinarians put a lot of efforts into saving our animals. Dr. Vairamuthu, and the list goes on and on. Dr. S. Shivaraman, I don't have anybody. If I have missed somebody, my apologies. So AVD is encouraging. The whole idea of AVD is to try to get to a college of dermatology or a diploma. So it is a long path, which is a 7 to a 10-year path that we have chalked out to get to that thing. We would like all the young veterinarians to present their work. So whatever work you are doing in your clinics, send in your papers. We will give you the opportunity to present them here. I welcome each and every one of you. Thank you, Kerala, for supporting us. Thank you, all the veterinarians across the country, for supporting you. God bless AVD.
Thank you, sir. Dr. B. Nagarajan, President of AVD India, is the backbone of this association as well as this Indian Congress for Veterinary Dermatology. He has over 8 years' experience in Animal Husbandry Department, Tamil Nadu. He is retired as a professor and head of the Department of Clinical Medicine, Madras Veterinary College, with over 30 years' experience in teaching. He has guided over 15 MBSc and PhD students and was proactive in initiating the dermatology ward at MVC. Dr. B. Nagarajan was also former secretary of the prestigious Asian Society of Veterinary Dermatology. He is currently an active member of the European Society of Veterinary Dermatology and administrative committee member in World Association of Veterinary Dermatology. I wholeheartedly welcome you, sir, to give the presidential address.
Thank you. See, first of all, I welcome all of you for this wonderful evening. I'm very happy to see you all for our second Congress. It's my privilege to welcome all the distinguished guests, delegates, speakers, faculty, students, friends, and representative of all pharmaceutical companies who helped us a lot in this. After the grand success of first international conference at Madras Veterinary College, Association of Veterinary Dermatology hosting second international conference in Kochi. So this we have selected because as Dr. was telling, it is God's own country, and we have got very much impressed. Personally, I felt, because I started my career in Kerala. See, just I started my work in this thing, our Palkad, KLD MMB, that is the first place where I worked, and I joined in veterinary college as a faculty. So initially I worked in animal husbandry department. So I thought first we'll start with the veterinary college, then we'll start with the second we'll go to Kerala, then we'll go like that. Each and every state will be covered in future. First we'll come out with all the states one by one. So it will be a distributed way we will be doing it in future. And the organization comprises like-minded people and veterinarians, subject matter specialists, biomedical scientists, and physicians in all specialties interested in the disease, particularly in the skin disease, diagnostics and research, and amazing animal skin and integumentary system. The association has been started with the aim of promoting greater education, research, and animal care, which will proactively work in collaboration with the national and international bodies to ensure the development of infrastructure for all advancement of veterinary dermatology and to attain heights of standards for veterinary practice in India. So we always, when we go abroad and see all the people and other faculty members and practitioners in other countries, we thought, why can't we start here by ourselves, and we will develop, because we have a lot of scopes. We have got a lot of wide varieties of diseases like lumpy skin disease. We have got need to develop ourselves. So like foot and mouth we have got cowpox, we have got camel pox, we have got a lot of fungal infection in camels in Rajasthan area. Likewise, wide varieties of disease of skin, not only in dog and cat, but also in case of large animals. So we thought of going for serious into it. So we have done. So the scope of our IAVD will provide professional continuing veterinary education, seminars and symposium, conferences, hands-on workshop, encouraging attendance to international programs by veterinary dermatology, particularly the World Association of Veterinary Dermatology conducting regular programs. We will be attending it. Our goal is to provide the base from which we will attain international standard for veterinary practice, dermatological practice for our country veterinarians. That is very important. So adding feather in the cap, we are proud to be a provisional member of World Association of Veterinary Dermatology during 2021 as a token of various activities and performance by the IAVD. So on behalf of organizing committee, I sincerely thank and appreciate each and every one of you for the overwhelming response and interest in veterinary dermatology. I request that this tremendous spirit should come and should continue in all our future dermatological activities. I am confident that all participants will cherish and sweet memories of this conference for a longer period. Thank you. Thank you.
Thank you, sir. It's with great pleasure that I invite Dr. Eliza Maina to release the manual of workshop for the second Indian Congress of Veterinary Dermatology. Madam, please. Thank you all. This Congress of Veterinary Dermatology is complete only with the release of the compendium. I invite Dr. Chiara Noli to honor the occasion and release the compendium.
Thank you all. With this, we have come to the end of the CVE Symposium, inaugural function. The first CVE Symposium will be on canine dermatology, parasitic dermatitis and skin tumor. The first session will be handled by Dr. Eliza Maina on clinical approach to common canine parasitic dermatitis. I request you, ma'am, to please take over.
Thank you very much for being here. The first presentation of today is about parasite, clinical approach to common canine parasitic dermatitis. As in any dermatological case, the diagnostic approach for parasites should be done systematically. First, we have to take the history. The main reason for visit to the vet with the parasitic disease is pruritus. Although pruritus is a common manifestation, its absence does not rule them out. So, first, when we have an itchy dog, we have to ask about the breed, the general health status, age, environment, if there are signs of contagiousness, therapy, duration of the itch, seasonality, intensity of the itching, and localization of pruritus. In the next slide, we will go through this. So, breed, why is it important? There are breed predisposition for atopy. So if we have a French Bulldog, Labrador, Golden, Terrier, Dalmatian, Boxer, they are predisposed to atopic dermatitis. So think about this when you see these dogs. West Island, Basset Hound, Shar-Pei, Sphinx, they are predisposed to Malassezia dermatitis. Yorkshire, they can have a generalized dermatophytosis. And Persian cat, they also can have dermatophytosis and also idiopathic facial dermatitis. For example, if during your visit you see a French Bulldog which is very itchy, you may think about allergy before thinking about parasites. If you have a West Island or a Basset Hound with this pruritus on the neck region, intense pruritus here, you should think about Malassezia. And also Sphinx, they can have a lot of Malassezia, more than the other breed. They can have on the body and around the nails. This was Yorkshire. This Yorkshire has a generalized dermatophytosis, and in the other picture you have dermatophytosis in Persian. The general health status is very important. If you see that the cats are really debilitated, they are living in unsanitary conditions, you should think about lice. You can cat with also fever and fever, they can also have demodicosis and also Malassezia. Here is a cat that has lice on the fur. And in the other slides, you can see dogs with a demodicosis, generalized demodicosis. Age of onset is very important. Puppies, a dog that has been bought a few days before your visit, think about contagious disease. If they are young, also think about food allergy. Food allergy starts in a very young subject. Between 6 months and 3 years of age is the window of time for atopic dermatitis. When an animal is old, start thinking about tumors. Here is a dog with generalized itch, which present a lot of seborrheic spots on the dorsum, and this was affected by Klebsiella. Here is a dog with generalized Demodex, and in the other picture you have a cat with dermatophytosis. You see that these are a very young dog and kitten. Here we have a middle-aged French Bulldog, which present pruritus and erythema, also lichenification and hyperpigmentation in the ventral area. This dog is also scratching a lot the muzzle, and is affected by atopic dermatitis. This one is a very old dog that presents depigmentation of the nose. He's losing the structure of the nose and depigmentation of the eyelid. This dog has epitheliotropic lymphoma. The environment is very important. Ask if there are other individuals in the family or in the group of animals in the house that lives with your dog that are affected. As you can see in this video, in the same house there were a lot of other dogs that were scratching. These dogs were affected by Sarcoptes. Another parasitic problem that is contagious is dermatophytosis. Sometimes the owner, they just forget to tell you that they have lesion. They don't think it's related. So just ask, please, all the time if there is someone else that presents a lesion. The pharmacological anamnesis is also very important. You should ask if the animal already received any treatment for a parasitic infection, because it is very important that you ask this, because if they didn't give, you could maybe think about a parasitic disease. You should ask if they already gave antibiotics, and if these antibiotics were effective. Probably it was just a pyoderma. If the antibiotics were partially working, allergies that were maybe infected with the skin bacteria were the most likely diagnosis. And also autoimmune diseases tend to improve with antibiotics, but they are not healing with that. Parasitic infection, they are worsening with the cortisone. Sometimes we are able to see in the skin scrapie sarcoptes because the owner, the vets gave cortisone, and so the sarcoptes start to proliferate more, and finally we can see on the skin scrapie. Food allergy also tend to respond less to the cortisone than atopy. Duration of itching. Ask when the problem starts. We saw this morning a Labrador that was itchy since 2 years. So allergy tend to be chronic problem. If the owner experienced pruritus with a recent onset, maybe infection and parasitic disease are more likely. Also, seasonality is very important. Maybe this more in Europe than here, but in Europe we have from March to October a high concentration of fleas, so infestation of fleas, but also hypersensitivity to flea. We have a trumbicula in the late summer, autumn, and we have also seasonal atopic dermatitis. So, just to explain you, if owner comes to you because the dog is itchy and you ask when is itching, and he said just from March to September, and this is the 3rd year that he does like that, don't take in consideration food allergy. Food allergy is all year problem. Here is an infestation with the trumbicula. As trumbicula is an infestation which is caused by the hexapod larva of a tick. So what you find on the animal is the larva. Is the larva that parasite the animal. The adult live free. So here is a group of these mites. We can see them. They are also easily to recognize because they have this really yellow color, orange yellow, as you can see here. We can find them on the ears, on the interdigital space, and they are very itchy. The intensity of itching is also important. If the pruritus is light, think about atopic dermatitis, bacterial infection, Klebsiella. If it's medium, atopic dermatitis, food allergy, malassezia infection, bacterial infection, epitheliotropic lymphoma. If it's severe, think about sarcoptic mange, food allergy, malassezia infection can also be sometimes very severe. It can also complicate allergies, and the pemphigus foliaceus as well. Localization of pruritus. If it's caudal, think about polycosis, flea allergies. Dorsal, Klebsiella. If only the ears are involved, think about food allergy, otodectes, trumbicula, otitis. If we have here elbows and belly, side limbs, think about sarcoptic mange. We saw the Labrador today, and I told you, this area that he had a lesion on the external part of the elbow, and he had also involvement on the external part of the pinna. This was suggestive of Sarcoptes mange, but we will see later is not pathognomonic. Extremities, food allergy, atopic dermatitis. We can have also pododermatitis, interdigital furunculosis, and trombiculosis. Only ventral, Sarcoptes mange, atopic dermatitis, and food allergy again. Here is an example. We have a dog that was really itchy on the dorsum, and he presented alopecia. This was a self-induced alopecia. This dog is more in the perianal area with intense erythema and also little sign of excoriation caused by the itching, scratching. And this was a dog with flea bite hypersensitivity. Here a dog with achilles, as you can see, is the dorsal part. The ears. Ears are very important because if you have a problem inside the ear canals, an intense itch inside the ear canal, you can have an otitis, a bacterial or yeast otitis. You can have otodex cyanosis in cats. They are pretty easily to be seen. It's enough even to just look with the otoscope. You can also take a swab and then put on the slide and check in the microscope. If, on the contrary, is the external part of the pinna, this can be or allergy, or as in this case, it can be notohedrous, which cause crust on the ears. Sometimes with the same type of lesion, we can have a crust but just caused by the itch, for example with the trombiculus. And if the crust or the pruritus involve the inner part of the pinna, this is pemphigus. Ventral part of the body, which involvement also of the elbow, ears. This is a case with the Sarcoptes mange. So the ventral part can be associated with the Sarcoptes mange. But be careful, it's not pathognomonic. This is a dog with atopic dermatitis. This is a dog with a food allergy. And this is a dog with Sarcoptes mange. So please don't think just about Sarcoptes mange. And the absence of pruritus does not rule out ectoparasites. Here are different diseases that are not associated with the pruritus. We can have tick, above all the nymph of the tick, they can be present, they can cause inflammation, but without being noticed by the animal that is not itchy. Here is a dog with demodicosis, localized demodicosis, which is not itchy unless it is infected. Dermatophytosis in cat. Here is miasis, also they are not itchy. They start to be itchy when it's sur-infected. And here was a dog with trombicula, sometimes is not itchy. As I said, if it's not itchy, you should anyway to ask if it's contagious. Dermatophytosis is contagious but not itchy. Demodicosis. Cats can have also demodex too. We have three types of demodex in cat. We have, like this one, is the demodex gatoi, which is an unique amongst demodex mite. It possesses this stubby appearance, as you can see here. It's a short body mite, and instead of living into the hair, it stays in the keratin layer. And this cause, and it is contagious, is also pruritic sometimes, but has this unique characteristic to be contagious. Normally, Demodex is not contagious. This is Demodex cati. Demodex cati is a long body mite, and this lives into the hair follicle and ears. Disease can be, like for Demodex canis, can be localized or generalized, and we can have a lesion when it's localized around the periocular area, can be on the head, on the neck, and we recognize them like for dog with this lesion of alopecia, and they can be associated with erythema and sometimes also with the pruritus because so infected. This type of disease can occur at any age, in any breed or sex, and this one is not contagious. We can find with any underlying causes, so idiopathic, but most of the time is associated with a status of immunosuppression or metabolic disease. There is a third one that has been recently identified and still has no name, so it's called unnamed Demodex mites. After history have been obtained, through clinical and dermatological examination has to be undertaken. We have to understand which are the primary secondary lesions, and we have to record them and try to create in our head a list of possible differentials. Let's see. If we have a pruritus and erythema together, it's easier to think about malassezia infection, allergy, epidiotropic lymphoma, drug reaction, and demodicosis. Here you can see we have a malassezia infection. We can have this one is epitheliotropic lymphoma, and this is demodicosis. Pruritus and papule, sometimes with crust, is Sarcoptes mange, pyoderma, food allergy, and flea bite allergy in order. So here is Sarcoptes mange, pyoderma, food allergy, and flea bite allergy. Pruritus and pustules we have in pyoderma. We can have in pemphigus foliaceus. These are, if you see these two pictures, you can notice that pustules are not seen anymore because pustules are really fragile in pemphigus and they will break immediately and you see a crust. This crust is yellow, is really yellow. And so when you see yellow crust on the paw pads and in the internal part of the pinna, think about pemphigus foliaceus. You can have also pyodemodicosis, for example, in the legs of this dog. Pruritus and multifocal alopecia you can have in bacteria folliculitis, in dermatophytosis in dog, like in these two, and in demodicosis. This was dermatophytosis, this is demodicosis. This one is a dog with also pyoderma. Voilà. Pruritus and exfoliation. Klebsiella, we already see that. Bacteria folliculitis, we have a cholerae and the pemphigus foliaceus. Pruritus, hyperplasia, and lichenification. These are lesions that we can find when the problems are getting really chronic, and it can be secondary to malassezia dermatitis, which looks like that. Something that can help us to think about malassezia is the presence of this, it's like a little seboria, yellow seboria that is around the erythema and the hyperpigmentation that you can find here. This is kind of typical of malassezia dermatitis, and the skin appear very greasy. You can have a chronic pyoderma and also chronic inflammation in atopic and in food allergy. Unfortunately, there are no pathognomonic skin lesions. Here an example. This was a dog that I was following for an atopy, and as you can see, he has a lesion in the typical localization of allergy. So in the groin, he has erythema in the groin, in the axilla, and also is leaking the pores and around the muzzle. In the last period, it was not under control as always. He was very itchy. And I saw the dog. After that he went to his vet. So his vet gave a little bit of cortisone for the flare, but the dog was not improving. And the owner reported that actually it was worsening. When I checked very well this dog, I realized that there was a little lesion that was not really typical of allergy. Here, unfortunately, I don't know if you can see, there is a little alopecia in this part of the tail. He was also scratching a bit the elbow. So what he did is to perform, here you can see the detail. And when I feel it with my hand, I had the impression that there was a lot of little papules, and the skin was thicker. So I did the superficial skin scraping. I also did a deep skin scraping, and what I saw was the following video. Here already you can see an egg. Here you see a little friend that is moving. Unfortunately, we have to wait because I'm not able to change the video, but probably, well, here you can see better. Maybe. Just 1 second. Is that when I make video, I'm with one hand I'm using the microscope, with the other one I'm recording. But yes, here we go. Maybe. Voila, yeah, a little bit of imagination. Here you can recognize the friends. And this was a sarcoptes. Here you can see better. He's also moving. You can recognize him because it's a kind of round mite. He has not the hook-like cheletella, and he has a little ventosa to move into the skin debris. This is another interesting case. This was a French Bulldog or Boston Terrier. I think it was a Boston Terrier. He was so itchy on his face and also on the legs. You know, he had this little purple crust on the body, but it was really erythematous. So it was young, it was 3 years old, and in my head I said, sure, it is an atopic dogs. And good for me that I like to perform a test, so I just, first what I did, it was to collect, I did the cytology because I was thinking it was atopic dermatitis. And I saw this cytology and I said, wow, there are so many eosinophils. It's not so frequent to find them in the cytology of an atopic dogs. We can find in cats, but not in dogs. So I said, why? And so I went very well and I rechecked the dog and I saw, yeah, but this is too orangey for being just, exudation or crust. So I did a little skin scraping and I found a trombicula on this dog. Of course, when I did this presentation, it was the period of trombicula, so the same I found also in cat. This cat came to me because he had pruritus on the paws and here in the temporal region, like any allergic cat. But indeed, he had also trombicula. And here you can really appreciate the orange color. Look, it's like my Polish nail. And here is the video. You can see they were not really alive. I think the cat received an flea control 1 or 2 days before. So I was still able to see them, but they were not moving a lot, you see. We have several. Yeah. Here is my super video. Yeah, I have to change the way of making video. Now that we took the history, we checked the lesion, we should have finally a list of differential in our head. And now we can proceed to rule out this differential with a proper test. I'm doing only the test that I need to rule out one per one this differential that I have in my head. So I'm performing the skin scraping superficial to rule out the Sarcoptes. I do deep to rule out Demodex. Why? Because Sarcoptes is living in the superficial part of the skin and Demodex deeper. So if I do superficial for Demodex, probably I will miss it. The superficial skin scraping can be done or with a little blade as we perform today, but it is also possible with a Volkmann spoon. I personally prefer because not all the time the dogs are gently like this morning. Sometimes they are moving, sometimes they are trying to bite you, so I don't want to have a blade in my hand. It is the superficial skin scraping has to be done as we performed this morning on the external part of the ear, but it can be also done on the elbow. It is better if you remove the hair, otherwise it will be not easy to collect all material that you had. The deep skin scraping, the superficial, very important. Since it's very difficult to find the Sarcoptes, you should do the skin scraping in a large area. Don't do just a little portion of the skin, because otherwise you will have a less chance to find the mite. On the contrary, when you do the deep skin scraping, what is important is not the surface, is how deep you go. The deeper, the higher are the chances that you find the Demodex. It's better? So here an example with the Volkmann spoon. You should really do it until you see the bleeding. And where I would do, in a Demodex, look for comedons. Where the skin is turning gray or bluish is there that you should do the skin scraping. You have more chance to find the Demodex, because the Demodex, if they are several into the hair follicle, they mix this material and you will see the comedons. So if there is a comedons, probably there will be also Demodex. You can use also acetate tape impression, and this is for the surface. So if you want to find the lice of Keletiella, which they live in the surface, you can do the acetate tape impression. You can do also for Demodex, if you squeeze the skin not really gently, you have the possibility to squeeze the demodex outside, and so you can maybe find even with the acetate tape. You can also pull the hair out and do the thoracoscopy for checking the demodex. And this is particularly interesting where if the lesions are in areas that are not so easy to be sampled, for example, around the eyes. It's perfect test also for Klebsiella, and here you can see we can do also the coat brushing in a dog that this was a Cavalier King Charles with intense pruritus, and it was full of squams. He had a lot of dry seborrhea, and so I did a lot of the coat brushing, and then here I think you can see how many I had, and I collect with the scotch, probably. Voila, like that. I try to collect really the majority of these squams, and I check in the microscope, and Klebsiella was there. We use coat brushing not just for Klebsiella but also for fleas. Here another example, but we already for fleas I'm trying to cover. I try to brush all body and not just the dorsum. Seems, at least in my opinion, that fleas loves this area and also the back part, so I insist a little bit on this part. Here is another dog where I collected the Klebsiella with the scotch, and here is what I'm doing when I'm looking for fleas. So I really try to see the skin, and it has to be quite quickly because the fleas are moving very fast. And for fleas, you can also check the pet coat for any black bits of dirt. You can collect them. You can put onto a piece of wet tissue or cotton wool, and then you gently place the dirt on the wet cotton, and if it turns red-brown color, then it's a flea dirt, because they are eating blood and they are doing stool that are containing blood. There is also the possibility to do the intradermal test for fleas. Remember that this is a delayed reaction, so the owner should control for presence of will in after also 24 and 48 hours, even 72 hours sometimes. Trichoscopy is performed for dermatophytosis, lice, sometimes Klebsiella less often, and Demodex canis. So you collect the hair, and then you check on the microscope looking for or dermatophytosis. Here is a hair shaft that contains a hyphae, and this is a Demodex well installed inside the hair follicle. And here is an example of the technique. So first I put some of paraffin on the slide, and then you can use two techniques which honestly are similar. One is with a forceps. This actually was my dog, and these are scars, but I use it just to show how to take. I advise you to put the hair all the time in the same direction, so with the root in one side and with the tips in the other side. This will help. And then there is the other technique, is just pulling with your finger. I prefer this one because I feel the impression with the forceps, I damage, I can break the hair, so I prefer like that. And then you put on the slide, roots in one side, tips in the other. You notice you put the name of the animal and you check on the microscope. Voila. We perform the ear swab and then we check on the microscope for different reasons. This is a test if you want to see if there is an infection with yeast or with bacteria. So, and also for autodex tests, I notice. Sometimes you can also find Demodex. And then you can perform the otoscopy and you will see directly the white otodectes. You can see here. Sometimes they are just in the middle of the wax. It's very dry and color coffee. Here you can see. It's kind of easy to find these mites in cytology. You can collect with a swab. There was also an article showing that you can also use this Folkman spoon. I personally don't like too much. They are moving. Sometimes I hurt these animals, so I prefer still the swab. Ear cytology, after that if you think that the animal has an otitis, you can take the swab and then you roll on the slide. I use normally only one slide. I put in a half slide the right and the other slide I roll the left, so I can save one. And here is the ear cytology, but it's nothing very difficult to perform. Sometimes we don't find, for example, malassezia if we are too superficial, so try to be sure to take a good sample. And voila, in the same, and then I'm doing in the other ear. All the time, my poor dog. And then I roll in the same slide, but the under part. And here I'm doing. Voila. Ear cytology, you slide with the frosted edge, you identify sample with a pencil, and then you stain the slide and crystallize this type. And you can also, I will explain later for ear cytology. So what I'm doing is I use all the three staining normally, but if I suspect only malassezia, or just cocci, I can just use the blue actually if I'm going to examine it immediately. I did them on the blue color just for 10 seconds, and it's enough because malassezia in cocci takes this color. Here is malassezia otitis. As you can see, there are several yeast which they have this peanut shape. And then I check on the microscope the sample. So what I'm doing is all the time I use the very little magnification. I want to have a clear picture of what is happening in this slide. Sometimes if we are too fast and we are going immediately to see our sample at 40 of magnification, we risk that we are just checking something that is not representative of the whole slide. So start with the small and then you go with the higher magnification. Serology. Serology is done for Sarcoptes mange. As I said, the Sarcoptes is very difficult to detect. There is a negative scraping in 50 to 80% of cases. Once a colleague of mine told me, no, it's just that you are not really careful. You are not really looking the slide very well. We are too fast. So I start to spend even half an hour looking this slide. No, I'm sure they are not so easy to find. So anyway, there is this test that can help you to understand if the dog was infected with Sarcoptes. There is only a problem that the seroconversion may need 5 weeks. So if you are performing this test too soon, you may have a false negative. And also, if you perform this test 1 month after the treatment, you will not find the antibodies. Be careful, because there is a cross reaction between Sarcoptes scabiei and dust mites. So what does it mean? That a dog with atopic dermatitis can have a test which is positive for Sarcoptes. So it is important that you exclude the scabies before performing serological allergic tests, because it's also possible the opposite. Diagnosis for dermatophytosis. There is not one test that is better than the other. So most of the time is the combination with anamnesis, clinical signs, and one or more of these tests. If you perform the fungal culture, this is pretty sensitive. The problem is that it can take 3 weeks to have the colony growing up. But if it's positive, then it allows you to collect a little bit of the material, to check in the microscope, and you can recognize and identify which type of dermatophytosis is it. There is also possibility to do the wood lamp test. However, it's positive. Already it's tricky to recognize a real positivity. It has to be yellow apple color, green apple color. And sometimes presence of crust can really give you a negative, a false positive reaction. And it is positive only with the Microscopium pruncanis, and not with the other type of fungi. And not in all Microscopium pruncanis. There was a test, an article saying that it was 60% of only one dermatophyte. So yes, if you have in your practice, use it. But if it's negative, you have any way to test it in another way. And currently, I'm doing both. I'm doing the fungal culture, and I'm also doing the PCR. PCR is very sensitive technique, so means that if you have a positive test, it may be that it is a real positive, but it also can be that the dog had it, or it was contaminated, and now is not still infected with that. So you can have the false positive. But if the test is negative, you are sure that the dog is not infected. So when I perform this, is because I want to answer to a question: the dog is infected or not? If it's not, for me it's okay. I can be sure of this result. But if tell me that is positive, I'm waiting anyway the result of the fungal culture. Because if the fungal culture is positive, means that the fungi has still the power, so it's still alive enough to grow and to show me a colony. Okay? So I perform all the time both. The treatment. When you have a parasite, you have to treat them. If you don't find a parasite and you are doing the workout for the allergy, you have any way to treat the animal. We can use isoxazoline. These are the newer treatment for parasites, and we have different. We have fluralaner, lotilaner, sarolaner, foxolaner, and now there is the esafoxolaner for cats. They have been used all for also for the modicosi with excellent results. Isoxazoline are a new class of antiparasitic drugs. They act on GABA and glutamate receptor of mice, so they block this receptor, they goes in a hyperstimulation and they die. They are oral and they are also in spot-on administration, and depending on which one we are talking. There is no interaction with other drugs. They are safe in dogs that are they have drug sensitivity, so the MDR dogs, like a collie. We can give in breeding and lactating animals, and the dogs has to be older than 8 weeks. I said that they gave excellent result for treating the Modex. Normally I give one per month, and I recheck the dogs every month until negativization. They have been used also in cats for both type of demodicosis, for Gattoi and for Gatti. And remember that most of the time the animal come to you that is been a while that he was scratching, so probably he has also secondary infection. So if the lesions are not so severe, start with chlorhexidine shampoo or association between chlorhexidine shampoo and spray, or benzoyl peroxide, which is also helping in cleaning the hair follicle. It's better to do this to avoid multi-resistance, that is quite a big problem now. Of course, if the animal has a severe lesion, antibiotics is also permitted, and these I use normally for generalized form or when topical therapy is not effective or not possible. Imagine a San Bernardo of 60 kilo, maybe we don't use the shampoo. However, I'm trying to do all the time the cultural sensitivity test before giving an antibiotic. Other treatments that are possible are the macrocyclic lactones like selamectin, moxidectin, prinomectin, tigolananer. Now we are not using anymore because we have isoxazoline, which are safer, but before we were also using Amitrax, fipronil, and also other products that you can read here easily. But please remember, before moving on and exclude the parasite, treat anyway them, even if you don't find them. Thank you. Are there any questions? Moxidectin normally no, it has to be, we should anyway use with carefully in dogs that are MRDN1 positive. But normally, yes, because it has a less negative effect than ivermectin. Do you have Bravecto, I saw? Yeah. Okay. Do you have also Simparica and Nesgard? Okay, so use them, they are safer.
Bravecto can be used in 3 months of interval regularly.
Is a very good point. I said I use them one per month, the other. Bravecto I use just one every 3 months. I check anyway the dogs after 1 month, but the dog received only one Bravecto. And something that I do is then I suggest to the owner anyway to continue with that treatment as flea and tick control. Above all, if they are not neutered, because the Modex can be for the dogs can have a relapse with the heat, for example, or with a stressful situation. So in this case, I prefer, or also if they are atopic dogs that had a Demodex, so they sometimes need cortisone, I prefer to keep them on the Bravecto one every 3 months or Simparica and Nesgard every month. You're welcome.
Can I use any antibiotic drug to reduce
in sarcoptes, can I use any antibiotic drugs to reduce itching like steroid?
Yes, it's a very also good question. I will not use cortisone, but I will use oclacitinib, for example. You can give for the first 10 days because indeed when you start to treat the sarcoptes mange, you can have a flare because of the mediators that are free, and so they increase the pruritus in this dog. So it's a good association to the Simparica or whatever to give maybe 10 days of Apoquel, of the oclacitinib. Yeah. I will avoid the cortisone, but oclacitinib, yes. And probably also an injection of lokivetmab, we will see later, but probably it will work less because it's a little bit less anti-inflammatory. It's not anti-inflammatory, it's just anti-itchy. Okay.
Thank you, doctor.
There is a question.
The last one.
What can be used in a 2-month-old puppy suffering from mange, sarcoptes?
Sorry, I didn't understand the question. Can you repeat, please?
What can I use in a 2-month-old puppy?
In a 2-month-old puppy. If it's 8 weeks, you can use the isoxazoline. Otherwise, if it's less than 8 weeks, I use Stronghold, selamectin. Yeah. A question there.
Good to burn calories, man.
Hello. Doc, I had an 8-month-old Tibetan Mastiff which tested positive for dermatitis, and I prescribed. He was on Bravecto. So post-treatment, it started developing EPI-like symptoms. Like diarrhea, loose motions.
Sorry, I was distracted by this bee. Can you repeat it?
Yeah. So an 8-month-old Tibetan, 8-month, tested positive for dermatitis,
Okay.
treated with Bravecto.
Yes.
Treatment, it started developing EPI-like symptoms,
EPI-like syndrome?
exocrine pyruvate insufficiency. So
Okay.
So could it could there be any relation?
It's not described, but normally with any new treatment you can have drug reaction. There is an interesting score which is called Naranjo score, which gives you the probability that this reaction is associated. My advice is if this reaction is in 14 days after the ingestion of Bravecto, you should anyway report, because if you don't do it, the next one will not do it because it's not reported and we will not know. Yeah. But if it's in the next 14 days, it's lucky. And if above all, if it was the first or the second one that it was taking these drugs.
Round of applause, guys.
With the second. Are you ready? Okay. I can. Yes. Sorry, I was enjoy the sign.
Familiarization with products that help us in our daily practice is essential. So we invite Mr. Karthik Rajan, Business Unit Head of Sabavet, one of our platinum sponsors, for sponsor presentation.
Thank you so much, Dr. Prerna, and welcome to God's own country. I think this is the first international national conference that we are having in Kochi, and probably a prelude to what we are going to have in 2024 in February with Vasava. So it's great to be here and an honor. to be starting off the sponsors presentation with Savavet. So obviously, the core corporate value of Savavet has always been to enrich lives of companions. Most of the products that we have launched is obviously to do this one thing, to help you in enriching lives of companions and to keep the community better, safer for everyone. So most of the products that we have launched in the last about 10 years of our existence in the industry has been to either improve the lives of patients or to make the lives of patients stronger or in order to extend the life of patients. So that's what most of our molecules or brands have done. And we believe that by doing so, we will enrich the lives of companions and in turn, the community will be enriched. So our strengths, obviously there are 4 critical strengths that Savavet has. And one of the most important strengths is we manufacture quality pharmaceuticals. There may be some patients who have asthma here, or you may have relatives who have asthma. So one thing that I would like to share is one out of 4 nasal sprays that in India, people use is manufactured with a Sava ingredient. It could be an ingredient or it could be the device. And 50% of the puff caps that people use, whether it is for Cipla or Macleod or Micro or Intas or Zydus, it is manufactured by Sava. That's a core organization that Savavet belongs to. And because we are in the respiratory space, we have a very strong focus in R&D. So we have an R&D facility based out of Pune, which employs close to about 35 scientists, and none of the veterinary companies in India do have this capability. So we are very proud to have an R&D facility out of Pune, and many of our products, whether it is Fiprofort Plus or Caradil or Lisabin, most of these products are formulated by the R&D team. And I'm sure, once we have got many of these Lanards expiring in terms of their patents, we will be ready for a generic launch globally. The third strength of Savavet has been our pan-India presence. Right now we employ close to about 110 people on the ground. Whether you are in Dibrugarh or whether you are in Angamali, you have got at least one person of Sava meeting you. So we meet about 5,500 veterinarians who are in small animal practice on a monthly basis. Many of them more than twice in a month, and they are met by close to about 12 of my colleagues. And this is a very big team, and this is something that we are very, very proud of. And the last, the critical important skill that we always want to have in our team is we want to train them to gain your respect. And that's something that we have always tried to do, and we will keep doing it. So since we are going to talk dermatology for the next 3 days, I'm sure the dermatology portfolio of Savavet is what I will constrain my presentation to. It offers you an infinite possibilities, from management of flea, tick control to going to dermatophytosis and talking about antifungals, antibiotics. So you have a lot of possibilities that is possible with the use of Savavet's dermatology portfolio. The core product that will be our focus in dermatology is obviously Fiprofort Plus. It is one of the backbone of Savavet, and it's the first combination spot on to be launched in the country. 10 years now. We have had more than 18 lakh dose applications in Indian patients. 2 studies in Bombay Veterinary College and Chennai Veterinary College have clearly shown that if Fiprofort Plus is used on a monthly basis, you reduce tick and flea load, and that's what papers also suggest. Even the paper which compares Brevecto with Fiprofort Plus clearly suggests that you need to look at monthly dosage application and not just leave with one dose. And we are very proud that Fiprofort Plus is still a very, very growing brand, one of the most prescribed combination spot on in the country, even in an age where a lot of things are being talked about, Lenars and tinibs and other newer class of molecules, fipronil still holds a lot of weight in everyday prescriptions. So we talk about 3 specific benefits that Fiprofort Plus offers. One is definitely safety. We might be very much interested in getting efficacious results, but again at what cost? And at that point in time, a topical spot-on with less than 5% getting absorbed into the bloodstream definitely gives lot of difference, because at the end of the day, as clinicians, our aim is not to achieve just efficacy, but again also to keep the patient safe and also the pet parents safe. So as ma'am right now pointed out, that fipronil is specifically targeting the GABA receptors in the fleas and ticks and does not harm the GABA receptors of mammals. So in that way, it is a very safe product. And efficacy wise also, as I mentioned to you, both in Chennai and Bombay, when we did the trials, both the trials clearly indicated that Fiprofort Plus not only reduced the flea and tick intensity over a period of time, but again it also had a very important impact on the tick reproductive potential as well. So in that way, it's very safe. And obviously convenience, you just need to open, snap it off and then apply. You don't need to do anything else. So it can be applied by anybody at home or in clinic. So all these are the benefits that Fiprofort Plus offers. So we just move on to another product. Obviously this is going to be talked about again and again and again in the next 3 days. I am sure cyclosporin and oclocetinib will be talked along with steroids as well as other class of medicines that we have for canine atopic dermatitis. And the punchline for HMC itself says, patients pays with long-term results. When you invest in the stock market, you don't take your hands off immediately. You wait for the stocks to appreciate and do it little later. And that patience definitely helps you in the long term. And that's why we always say that cyclosporin is a molecule which is tried, tested with more than 20 years of pharmacovigilance studies. And not only that, at any point in time, the beauty of cyclosporin is that you will be able to reduce it, taper it down to the lowest possible dose, to the lowest possible frequency, which no molecule at this point in time, which has been approved by FDA for the management of canine atopic dermatitis, can do. So that is something that we have been very proud of while promoting this product. Even Dr. King's study from Zoetis does mention that once you move from a 2-dose frequency to a single dose frequency, you definitely start getting seeing patients to get scratching more. So, but on the other hand, you will see cyclosporin gradually decreasing in terms of pruritus. So this obviously we'll keep discussing again and again in the next 3 days. So HMC, which is now for dogs the most prescribed brand of cyclosporin in the country, is now labeled for cats also in feline allergic syndrome. So at a dose of about 7 milligrams per kilogram body weight. So it can be used in cats. Before I move to the next product, I just leave you with some thoughts, few slides, which I have picked up from few papers. The first thing is obviously a statement by Dr. Rosanna Marcella of the University of Florida. This has come up in one of the proceedings which has been done by a company recently and published in Clinician's Brief in last May. She says that itching has to be controlled. Without the itching being controlled, it's very tough. So once the itching stops, you give patients a little breather. You will ensure that the patient's quality of life improves. Thereby, for a few nights at least, the patient and the pet parent sleep well. So that is most important, the control of which is absolutely important in canine atopic dermatitis. But again, unfortunately, atopy is like the stock market. You don't see stocks either appreciating or you don't have stocks depreciating continuously. It's like your Adani stocks, it goes up and down, up and down. It doesn't stop at any position. So it is like a stock market where anything can happen at any point in time. It can go up and down. And here, like any stock market, you need short-term gains, but again, you need to have long-term returns. And if both these have to be combined, and I would like to quote from Dr. Thierry Olivry, who also wrote in a paper in 2019, where he talked about the the quest for the holy grail in canine atopic dermatitis, where he talks about whether a single molecule or blocking a single receptor will help you, to inhibit all those signs, associated with canine atopic dermatitis. And he goes on to say that unfortunately this entire concept of developing molecules to have one point of interaction with the immune system, and that in turn will stop the release of cytokines, or then everything will be stopped, is fundamentally wrong, primarily because atopic dermatitis, as every one of us know here, is not a disease. It's a syndrome. So it is definitely a complex immunological cascade which has different types of lesions at different stages in the life of a patient, which is also different between breeds, which have different genetic origins. So if all this is true, the chase for one molecule may not be the correct one. At any point in time, you also know that there's an interesting paper which has come in veterinary dermatology now, which talks about, have we moved away from steroids? No, I don't think so. We need steroids, we need cyclosporin, we need oclacitinib, and we need more molecules at different points in time of a patient who is having canine atopic dermatitis. So this is the 4 slides that I wanted to leave you before the discussions will definitely happen during the course of this conference. So the other product that we launched during the course of last year was Celafort. Now, as you can see, it's time to twist life, turn life with a little twist. And we were not the first to launch selamectin in the country. The original research product had been launched about 3.5 years back, and there was a host of generics that had already launched. But again, you have known the molecule, you have used the molecule, and you have also seen a lot of variability in results. And one of the most important reasons to appreciate when we talk about variability in results is that we are providing, the industry is providing selamectin to the clinicians either in a polypropylene or a polyethylene bag or a tube. Now, unfortunately, selamectin is a much more oily liquid or molecule as compared to fipronil. So it is not possible to seal selamectin within the tubes which are conventionally available from many different generic companies. So what we did was to go back to the drawing board and find a very reliable, hassle-free solution. The solution came from Switzerland, from a company called Hoffmann Neopak, who have provided us with an award-winning dispensing design, which is very, very aesthetic in its presentation. It is a pre-printed tube, it's a polyfoil tube. We have aluminum coating inside, and we have the polypropylene packaging outside. Now what does that do? It helps to increase the barrier which selamectin gets from environmental damage. At no point in time the tube is exposed or the contents is exposed to environment. Normally, whether you use the original research product, you punch it and open it, apply it. If it has been in generic companies, you snap it off, you rotate it and then apply. In our case, you just need to twist the cap. The orifice is open only one time during the entire application. And that is the only time when selamectin gets exposed to the environment. And this achieves what? This achieves superior results. It does not allow the selamectin to get broken up due to environmental exposure and moisture. So this is what we are doing. At no point in time the cap separates out of the tube. It is a tamper-proof tube. Once you open, you don't even have a click sound. You just have a little air coming out through the orifice, and then you just apply. So it is a very easy application, single dose tube that we have developed from Hoffmann Neopak, which is a Swiss company. Now obviously there are other products which are in dermatology portfolio of Savavet, and one product that we launched was a nitroconazole 10 mg per ml oral solution, and this is indicated for use in cats with dermatophytosis, and this is available as Felintra. We also have a tacrolimus topical ointment, which is 0.1%, 10 grams, and it is used not only for lesions associated with canine atopic dermatitis, it also can be used for perianal fistula. We also have Perdruff, which is a pyroxenolamine shampoo, which is primarily an anti-allergic shampoo, but again it also has about 7 botanicals which help to improve the skin's consistency or the quality of the skin, which is equally important, and that is again a brand that we have launched recently. We also have Kizopet, which is ketoconazole and chlorhexidine with a cetrimide shampoo. Then we have reintroduced W Shield, which is a wound healing ointment, which is our own formulation, and this contains the usual suspects which you see in all herbal ointments like curcumin, turpentine oil, cedarwood oil, and it's for wounds to heal faster. Staff Bam is a brand that all of you know for superficial pyoderma containing 2% muprosip. We also have for skin infection Cephalexin, which provides a tough cover for skin infections. And we have a host of brands, which all these brands are multi-crore brands, which have become multi-crore because of the support that it has enjoyed from clinicians. So Fibrofort Plus, which I've already told you, Safe Heart for congestive heart failure. We have got Carodil, which is carprofen for pain management. Lisabin is SAMI with Silibin, one of the first brands to be launched even before Denamarin came into the market, and Kivov Plus, which is our range of dewormers. And our antibiotic portfolio is something that we are very proud of. We have got 9 antibiotics, out of which 5 are oral antibiotics, 2 are topical and 2 are injectable antibiotics. It can be used for every kind, almost all types of infections that you regularly encounter. I'm sure there are 2-3 more antibiotics which will come from our side in the near future. So our journey continues from the last 10 years we have come until now, and we will definitely be holding your hands and moving forward in our journey to become the most admired veterinary company in small animal healthcare, and that's our dream, and I'm sure that will achieve. Thank you so much for all your patient hearing. Thank you so much. And before I leave, I'd like to thank Dr. Nagarajan for giving SavaVet an opportunity to be part of this conference, and we're very happy to be here. Thank you so much.
Hello. Thank you, Mr. Karthik Rajan. The gold sponsor of this conference is Vivaldis. Dr. Sergei, R&D Project Manager of Bioberica, Spain, is present here in association with Vivaldis. He obtained his degree in veterinary medicine from Barcelona and completed his doctorate in animal medicine from Barcelona. We now invite Dr. Sergei to handle the sponsor session of Vivaldis.
See, we are very happy to announce for 2 important announcements from SavaVet. One is lucky draw. 2 lucky draws are there. One is for the next Congress. They are going to support how many veterinarians? Please come. 10 veterinarians. Give a big round of applause.
It's like, this should be a continuous affair. So 10 veterinarians will get registrations for the next year's ICVD2 wherever it happens, and I know sir will tell. The other one is obviously a lucky draw, which will be for life membership of the IAVD. So both of them.
10 each. Thank you.
Dr. Sergei, we invite you to take over.
Okay. Good afternoon, everyone. My name is Sergi Segarra. I'm at the R&D department of Bioberica, which is a company based in Barcelona, in Spain. And today, together with our partner here in India, Vivaldis, we are delighted to present you something new, something different. This is a new product development, and it is a sphingolipid collar for atopic dermatitis. So as you know, canine atopic dermatitis is a chronic and frustrating disease. We normally opt for a multimodal approach, and adherence to treatment, so compliance is very important. So we need the collaboration from the owner, and we should try and make their lives easier. You also know that pruritus is the main clinical sign of canine atopic dermatitis. And lately, many publications are talking about topical therapy in order to restore the epidermal barrier integrity and function. So although there are many different therapies out there, none of them is 100% effective, and some of them have some associated adverse effects. So that's why we think that novel therapies, and especially new presentations, are needed in order to optimize this multimodal management of canine atopic dermatitis. So what we do at Bioverica is we extract biomolecules of animal origin, and then we try to give them some usefulness for animal, human, and plant health. And in this case, we decided to focus on skin health by generating some scientific evidence from some of these molecules. And in skin health, we thought, is there something that we can do in order to try and contribute and restore the skin barrier in this kind of patients? And also, can we help reduce skin inflammation? So that's why we developed an ingredient called Biosfin, which is a unique sphingolipid extract. This is a lipid extract that has been shown to provide benefits for skin health. We have done and published many different in vitro and in vivo studies. As you can see here, we first used an artificial skin model in which we show that we can improve the lipid profile of the skin with this lipid extract. We then did a study in canine keratinocytes in which we have shown that we can decrease the release of prostaglandin E2. We have also shown that we can enhance the expression of filaggrin, which is a very important protein, as you know, and we can also act and have an impact on the expression of antimicrobial peptides. So with that, as I was saying, we can act at different levels of the skin and also on different types of cells. First of all, we can increase the levels of ceramides, which are reduced in dogs and in people with atopic dermatitis. We can also increase the number of lamellar bodies, which are these round-shaped structure which contain lipids, lipid precursors, enzymes, and so on. So it's very important for the skin. As I said, we can also reduce the release of prostaglandin E2 and increase the expression of antimicrobial peptides and filaggrin. And once we have done all of this, we try that in vivo, combining this sphingolipid extract with glycosaminoglycans. And we did a study at the University of Florida with Dr. Rosanna Marcella in dogs with atopic dermatitis, in which we managed to show clinical benefits, namely a significant decrease in the pruritus visual analog scale, the PIVAS, and also significant improvement in the CADISI, which, as you know, is the canine atopic dermatitis extension and severity index. And so with all of that, we thought about going a bit further, one step beyond in our portfolio for skin health with two main goals. First, focusing on the vets. We wanted to provide vets, veterinary dermatologists especially, with different treatment alternatives, different presentations, so that we can contribute to this multimodal approach to skin conditions, and especially canine atopic dermatitis. And then we also wanted to focus on the owners in order to, again, to make their lives easier and to increase compliance so that product administration would be easier, optimize the treatment, and also, at the end of the day, revert in reduce monthly treatment costs. And that's why we came up with the idea of developing a new and disruptive product, which is a collar for atopic dermatitis. As you can see, it looks and it's very similar to the antiparasitic collars that you are very familiar with. This is a plastic collar, a polymeric matrix collar, which includes Biosfin, which is this sphingolipid extract that I was talking previously with all this scientific evidence for skin health. It also comes with lavender sand and with different sizes. As I will show you in a couple of slides, it can have a durational effect up to around 2 months. So it's very convenient for the owners. And then the composition includes a substance called plasticizer, which enhances the spreadability of the active ingredient, and I will talk about this also in the next slide. So we've done a study in which we have shown that the efficacy and safety can be up to 8 weeks. Stability tests have been performed with very good results. It also includes what we call a buckle security system in the small size. This is just when it's used in cats, for example, if they go up on a tree and they get hanged, so when there's enough traction force, the collar will break, and then the cat will be released, and that'll be a happy ending. And so, last but not least, we filed a patent application, so hopefully in the near future this will be a protected product, a patent-protected product. So first, as I was saying, it is very important to understand color technologies. So it is a polymeric matrix in which we add a plasticizer, and this plasticizer will expand this matrix. And this provides 2 main benefits. The first one is flexibility to the color, so you can bend it without breaking it. And the second thing is that it will enhance the release of the active ingredient from within the color into the outer part of the color. So here's the polymeric matrix with all these ingredients. And then we add this plasticizer, the active ingredient, the black dye, and also the lavender scent. So the black dye, first of all, because our colleagues from the marketing department thought it was nice, so it looks nice, but also because the black dye will protect the active ingredient from the UV light. So it's a technical issue too, so this is providing further stability to the product. We did an in vitro test in order to make sure that the kinetic release was adequate, and you can see here that this curve or this pattern is adequate, so it will be released when the active ingredient gets out of the collar. Because it's a lipophilic ingredient, it will get attached to the lipids of the skin from the sternum corneal and will be released and spread across the surface of the skin. And then we have performed a clinical study. This was done in order to evaluate the efficacy and safety of this new product in dogs with atopic dermatitis. We looked at different parameters, the KDC and PCAT that I was talking before, some side effects, quality of life, and feedback on the product from both vets and guardians. And the main thing here is that it was a single application. So day 0, we put the collar around the neck of the dogs, then you forget about it, and look what happens after 1 and 2 months. And if we move on to the results, feedback was very good from both vets and guardians. They seem to like the appearance, the color, the smell, the effects. No adverse effects whatsoever. And very good results in terms of efficacy. So we managed to achieve significant improvements in the KDC, the PCAT, and the PIVAS, as you can see here. So if you look at the first graph, from 0 weeks to 4 and 8 weeks, you can see there's a marked decrease, especially during the first 4 weeks, and then it is kind of maintained. The effect on the PCAT was also during the first month. And then this last one, so PIVAS was the evaluation done by the owner. So this is subjective, but this is giving us the a standpoint from the guardian, from the owner. I thought it would be interesting to also show you some pictures from these cases. So this is a case at 0, 4, and 8 weeks. And I'd like to draw your attention to this first picture here. So this is the inner part of the pinna, and this is after 4 weeks. And also this interdigital area at 4 and 8 weeks. So this would be like an indirect way of telling us that the product, although you place it around the neck, it will get spread and reach distal parts of the body. And we have just a single case of a cat. Performing studies in cats is difficult. We're getting cases even more maybe. So it was just a case, but it worked very well, also during 8 weeks. Again, main effects after 4 or even after 2 weeks. And well, everything that I've been talking about this and other ingredients that we have for skin health have been either presented at some scientific international congresses and then published in some scientific and peer-reviewed journals. So if you want, you can ask for that, or you can look it up online. And this is what we had for you today. So this is new product thought with the aim of making life easier for pet owners and for vets. And as I said, we think it would fit very well within this multimodal management of canine dermatitis. So yeah, with that, thank you very much for your attention, and I'll be happy to take any questions, or you can stop by this booth if you want. So, thank you.
Thank you so much, Dr. Sergi, for coming all the way from Spain for this session. And we would just like to launch our new product, that is the Topivet collar here. And for that, we want to cut the cake. I would like to invite the organizers as well as the speakers to please come on this stage. Thank you so much. And for any further details about the product, you all can please visit our stall, Vivaldi's stall. Thank you.
Thank you, Team Practice. The next topic is diagnosis and treatment of the most common skin tumors. I hand over the session to Dr. Eliza Maina.
Are you ready? Okay. So, in this presentation we are talking about tumors, so diagnosis and treatment of most common skin tumor. Tumors are abnormal growth of cells. Tumors are affecting the skin, and for this reason they are probably easily seen. They are also maybe so common because the skin is constantly exposed to many tumor-causing factors in the environment. Chemicals, solar radiation, and virus are just some of the causes of this tumor. Then we have also hormonal abnormalities and genetic factors that can also play a role in the development of this tumor. First, we will see the approach to our patients with a skin tumor. The appearance of a swelling or nodule in the skin can result from a very broad spectrum of inflammatory or neoplastic disease. So with the cytology, we can arrive to discriminate most of the time. So first, you have to assess the cellularity of the specimen, and then you have to decide if it's adequate or not. The second step is to be able to discriminate between an inflammatory and an aneoplastic picture. When you assess the slide, you can find or just inflammatory cells, so a tumor is unlikely, but you can find inflammatory cells and tissue cells. In this case of mixed type of cells, you should maybe check if there are infection, treat with an antibiotic, and repeat the cytology. You can also find tissue cells only. In that case, you can probably find a tumor. Be careful that sometimes we have inflammatory disease that they present only one type of cells. Fine needle aspiration, and you can do this sample with or fine needle aspiration or just using the position of the slide. Above all, if it's ulcerative. For example, if you have a squamous cell carcinoma, also ulcerated plaque in epitheliotropic lymphoma, you will find the neoplastic cell easily. Then, once you understood that is a tumor, you should understand which kind of tumor is, if it's a round cell, epithelial cell, mesenchymal, or melanocytic. You should also look for signs of malignancy, cellular and nuclear atypia, and mitosis. When you understood what is it, you should see where is it the tumor. Is a localized disease or a metastatic disease? This changes completely the prognostic. So you should perform the fine needle aspiration of local and lymph nodes, thoracic radiography, and also abdominal ultrasound, also CT scan, MRI when is advised. Is depending on the tumor. And the last question: how do we get rid of it? And this is depend on question number 1 and question number 2. When we have a tumor and we have to remove it, we have to think about to use a multimodal approach. Most of the time the surgery is not enough. You have to combine chemotherapy and radiation. Next, we have to classify the skin tumor. So we understood that it is a tumor, so now we have to understand if it's a round cell, epithelium, mesenchymal, melanocytic. Let's see which are the most important round cell tumor. We have mast cell tumor, lymphoma, histiocytoma, plasmacytoma. The TVT we don't have in Europe, so I think you are better than me in this. So let's see mast cell tumor. Mast cell tumor represents a cancer of mast cells, which are also called mastocytes. These are a type of blood cell which is normally involved in the body response against inflammation and allergens. It's considered to be the most common skin tumor in dogs. A very large-scale retrospective study showed that it was really the most common. In cats, it's the second most common cutaneous tumor, following the basal cell carcinoma. Mast cell tumor is typical in older dog. Is typical of older dog, but is also occur in a younger dog. There is no apparently gender predilection, and we have an incidence in some breeds. They normally are larger or giant breeds. Boxer, Boston Terrier are overrepresented, but honestly also Shar-Pei is very frequent. And in Shar-Pei we can have also very malignant mast cells. In cats, mast cell is the second most frequent cutaneous neoplasia, and is not so frequent. It's between 2 for 15% of all tumor in the cat. Is diagnosed also in older cat, and Siamese seems to be predisposed. However, in other articles, also Burmese, Russian blue, and ragdoll are overexpressed. In dogs, we have two types. So we have a cutaneous mast cell tumor, which are the most common, and they involve the dermis and the subcutaneous tissue. We can find most often on the trunk and the perineum. We can have in the limb, head, and neck. They are usually solitary. They represent between 11 and 25%. They are solitary, but in 11-27% of dogs they can have, although they can be multiple. We have also the visceral one. These are less common, they are most aggressive and involve the gastrointestinal tract, the liver and the spleen. They can also be in the lung and intramuscular. In cats, we have also two forms, the cutaneous and visceral, but in cats we have a mastocytic form, which is the most common, and then we have an atypical form. It's called atypical. This is a classification that is histological, and is just because they are not looking like mast cell, but they are more looking like histiocytic. It can be on the head and trunk, and they have more often the multiple masses. If they are multiple, this is associated with a shorter survival time when compared to the solitary. Visceral is in the spleen, liver, intestine, and it is more often more common. We can have visceral in 50% of cases. Here is the mast cell. The mast cell, when the granulating, is able to release a lot of inflammatory mediator. Here in this picture, you can see they are intact, and when they degranulated, they like just explode, and they get free a lot of inflammatory mediators such as serotonin, histamine, which are causing a reaction, a very inflammatory reaction. And sometimes the reaction is so strong that it can cause also problem in the gut. We can have also ulceration, and if there is a very big tumor, we can also have vomiting, diarrhea, fever, peripheral edema, collapse. What is interesting is that even if we stimulate, if we touching these lesions, sometimes we can induce this degranulation, and we can have erythema and will formation after that we touch this mass. This is called diarrhea sign. So if during your consultation you are touching this mass because you want to understand the consistency and the texture, and after 10 minutes you will see that it's getting bigger and also inflamed, it is probably a mast cell tumor. Mast cell tumor, they can cause metastases. Metastases are often local-regional, so you should all the time check also, do a fine needle aspiration of the lymph node, but it can also give distant metastases like in the spleen, liver, and intestine. Important, there is not one typical form for mast cells. It can look everything. If you check here, it seems just that this dog has interdigital furunculosis, but this was a mast cell tumor. In this case, it seems that the dog has just bitten the penis, or he had a furuncle on the penis. And here it can look any other tumor. This is a dog, is a Shar-Pei of 7 years old that arrived in my clinic, and the owner was thinking that was just bioderma. So when you see a mass, ulcerative mass in a Shar-Pei on the head, just think immediately to mast cell tumor. What is important is a very easy diagnosis. If you perform a cytology, a fine needle aspiration, you will find immediately that there is only one population and that they were mast cell tumor. So the diagnosis is with the cytology first, but it is very important to collect the biopsy. So biopsy is considered the gold standard method for sample collection. It is better to know what is it and to do the to understand which grade has this tumor, if it's more malignant or not, before removing everything. Once you collect the biopsy, you send for the histological analysis, because you want that they give you a grade. So what the histopathologist does is that they use two main muscle tumor grading system. So we have the QPEL, which is considered the super value. It's the two-tier grading system, so it will tell you if it's a low grade or high grade. Then they also do the PATNIC, which is the three-tier grading system, which give you more information about the prognosis. Sometimes they need also to do the molecular screening using different markers, like the proliferation markers and the expression of the CT kit, because it will give you also more information about the prognostic. As I said, there are different range of biological behavior, so it can be benign, but it can be also extremely aggressive, like in these Sharpeis I show you. And this can lead also to metastasis and eventually also to the death of the animal. There are several prognostic factors, but no one factor is entirely predictive of biological behavior. That's why you have to keep in mind, in consideration, everything that is in this list. Concerning the age, older dogs may have a shorter median survival. The breed, as I said, Sharpei, they have bad prognostic, and also in boxer they tend to be of low and intermediate grade, so they have a better prognostic in this animal. Sex, male seems to have a shorter survival time than female, and also growth rate, if they remain localized and they are present since a lot of time, they probably will be more benign. Systemic sign, if you have anorexia, vomiting, melena, this is a bad prognostic. Localization, sublingual, subungual, oral, and other mucosal membrane site, these are bad prognostic. And also recurrence, if you have a recurrence, this is a bad prognostic. Presence of the c-KIT mutation that I said before, and also a proliferation rate that is higher, these are bad prognostic factor. It is important also to do the staging. So one, you know that is a muscle tumor, you have to do the staging. Why? Because you want to be sure there are not metastases. So before doing a surgery, be sure that the lymph node, the liver, and the splenic area are not involved. Imagine that you find a dog with this small nodule, and you want to know if you have to remove or not, and how much. Once we were thinking that the good approach was to remove 3 centimeters for each part, and also 1 fascial plane deep. Now there is a new conservative approach for small, low-grade muscle tumor, which they think that 2 centimeters are more than enough for muscle tumor, but you have also to remove 1 fascial plane deep. It's for this reason that I said if you have a small nodule, don't try to remove as much as you can in the first time, because you don't know if this is still a benign or aggressive muscle tumor. So what you have to do is biopsy, and only when you know that it is small, low grade, you can be conservative. Why I should do, once I remove the muscle tumor, why should I anyway send again for the biopsy? Because you want to be, for the analysis, for the histology. It's because you want to be sure that the margins are clean. Otherwise, you have to repeat the surgery or use a different approach. For example, if you have a dirty margins or metastasis, you would like maybe to do the chemotherapy. Chemotherapy, there are different protocols that you can use. I'm not an oncologist. Normally my cases I give to the oncologist, but I know that they are doing a different protocol using or intravenous vinblastine and oral prednisolone, or only lomustine, or again intravenous vinblastine and lomustine, or a mix of the three. And normally they have a good result. There is a new drug, I'm not sure that you already have this, is a tigilanol tiglate, is a novel diterpene ester, which is now available in Switzerland. And this is an intratumoral treatment. So basically, you identify the nodules, you understand that is mast cells, and for example, for spatial localization where you cannot do the surgery, or in this case, the owner didn't want the amputation of the ear, we decide to do it. So normally, for example, if you have on the tail and you don't want to amputate, or the lesion is too big that you are not able then to close it, you can inject the stem funda. But be careful, it's very important that you inform the owner of what happened after, because this intratumoral administration leads to the destruction of the tumor mass in the next week. So what's happened is that you will create a huge hole in that, because it provokes a necrosis of the tissue. So the owner has to be aware of what is happening. So it's quite bad when you see this. But then they heal for second intention, they have a scar, and normally it works well. Another approach is the chemotherapy in English, and this is actually electrical pulse that are delivered through an electrode that you put inside the nodule. You give normally is a bleomycin that you inject intravenously, and then the combination with the chemotherapy and this electric pulse will help the uptake of the chemotherapy drugs by the cancer cells. It's not so expensive to have this technique, and it's work very, very, very well, and you can use it for several types of tumor. When you have a mast cell tumor, as I said, you can have also systemic signs, so keep in mind that you can also add products to protect the gut. In cats, mast cell tumors are less aggressive, so you can be less invasive in your surgery. Here you could remove really only this little part. You don't need the amputation. The behavior is much better. I have a slide to show you later. So anyway, even for cats, the ideal treatment is the surgery, but the incomplete excision of this tumor does not seem to be associated to tumor recurrence. Feline mast cell tumors tend to behave better than in dogs. The atypical form can also regress spontaneously, and multiple mast cell tumor can also they have a more guarded prognosis. It's important to do the staging only for multiple nodules. Here is where I will cut this here. Let's continue with the epitheliotropic lymphoma. Epitheliotropic lymphoma is a tumoral lymphocyte, which are a type of white blood cells, and they are cells of the immune system. There are two main types of lymphocytes that cause lymphoma. We have B cell and T cells. lymphoma is not so frequent, it's counting for 1% of the dog skin tumor, and they can be, the mass can be solitary or more often is generalized. Is classified as epitheliotropic or not epitheliotropic, and this difference can be done just by the histology. Epitheliotropic is the most common. It involves epidermis, mucous membrane, hair follicle walls, and gland, and is caused by T cells. Non-epitheliotropic lymphoma is dermis subcutaneous, is both T cells and B cells. We don't know why the dogs develop this tumor, but what has been suggested is that there is anyway a correlation between the dogs with canine atopic dermatitis and lymphoma. This is more often in older dogs, and English Cocker Spaniel, Golden Retriever, and Boxer are overrepresented. As highly variable, you can start very slightly, with a slight lesion. For example, in the beginning you can have just exfoliative erythroderma. Means that the dogs come to you just because they have scarring, erosion, ulceration. Sometimes, if you are lucky, they arrive with the depigmentation of the nasal, which is really pathognomonic, and alopecia. Then with the time, they present plaque and nodules. And some dogs, they can also have a mucocutaneous ulceration and also ulceration of the oral mucosa. Here, an example of the erythroderma. As you can see, there are scaling, there are ulceration and alopecia. Here we saw already today is a depigmentation of the nose and also of the eyelid. It's very important to see here, you don't recognize anymore the structure of the nose because there is edema that is swelling the nose, and this is already a sign that there is a problem. If it's an old dog that is presenting with this depigmentation, also the lips, think immediately about lymphoma. Here an example that ulceration of the mucocutaneous junction and also some plaques and nodules. Diagnosis is with the cytology. You already, if you have a nodulus which is ulcerated, you can use directly the slide. Otherwise, if you have a nodule which is not yet ulcerated, you can use the fine needle aspiration and you will find a homogeneous cell population of a lymphoblast. Histology is important for the final diagnosis because epitheliotrophism cannot be identified on cytology. Then you may need the immunohistochemistry or flow cytometer to understand which the immunophenotype. But sometimes these lymphocytes are really atypic that you need the clonality with the PCR to understand if it's inflammation or lymphoma. The treatment, there are several treatments, but the most important is lomustine, which is used between 90 and 60 milligram for square meter, and this is given just once every 3 weeks. Lomustine is a drug that can have severe side effects. For example, can give you myelosuppression and hepatotoxicity. So it's very important that you count the absolute number of lymphocytes and also the hepatic value every 3 weeks. You can give together the isotretinoin, 1 milligram kilo, once daily orally. And this is normal, the protocol that is most used. Other treatments have been used, for example, vincristine, cyclophosphamide, also masitinib, which is a tyrosine kinase inhibitor. But there are only very few cases in this study, so I'm not still suggesting to use these. I think lomustine and isotretinoin are the best. Then, if the dog doesn't respond, you can try other treatment. Also, radiation has been used, and let's see. Prognosis is poor. So the survival time after the diagnosis is a maximum 6 months to 2 years. But please don't tell that it's just 6 months, as in the majority of cases, because sometimes they can arrive also to 2 years. Euthanasia is often asked because of the poor quality of life of the animal. Anyway, the disease with the time progress and spread systemically. This is a case. It was a Cavalier King, old, 15 years old. He had plaques, crust, ulceration, and generalized alopecia. And as you can see, he had the pigmentation of the nose. He was very itchy, and it was smelly bad, and he didn't eat. Here was one of the lesion that he had, ulceration. It was a thicker, so it's plaque, ulcerative plaque. For me, the differential diagnosis were bacterial, demodex, dermatophytosis, also pemphigus foliaceous because it had anyway a lot of crust, and epitheliotropic lymphoma allergy. When I performed the cytology on this lesion, I could do just with the slide, but I did also with fine needle aspiration. This was what I saw. So they were all lymphocytic with several characteristic atypia. So I did anyway the deep scraping and the fungal culture because of this tumor they could have also demodicosis or fungal infection. They were all negative, and I did the biopsy. The biopsy confirmed that it was lymphoma. This case is very interesting because if you see, he had just multifocal alopecia, ulcerated plaque, and he was also itchy. And I remember it was just 3 years old. He's a French bulldog, came to me like that. I said, sure, he has a pyoderma because he's allergic. But then I did I gave antibiotics for 2 weeks, and then after 2 weeks he worsened instead of improving. And I had also large nodules on the neck. So I took the biopsy, and with my big surprise, because it was just 3 years old, he had an epitheliotropic lymphoma. We gave lomustine and isotretinoin, and the dog after 1 month was almost, it improved. So the size of the nodule was much less. This was a lesion that was on the neck, I think. Unfortunately, what's happened with the lomustine? You give one every 3 weeks, and they improve. Normally, you give 3-5 months, and then suddenly they worsen. And so there is nothing else that you can do, and most of the time it's the owner that decide quickly to do the euthanasia. Histiocytoma. Histiocytoma is a tumor that comes from a histiocyte. Histiocytes refer to the cells that they can be either macrophage or Langerhans cells. Histiocytoma is a tumor of these cells. Let's see. It's a common tumor that is more frequent in bulldog, pit bull, greyhound, boxer, Boston terrier. We can find it in the head, in the lips. I would say also in the ears very often. It grows very quickly, and it's in bed because it's ulcerated. Here is a dog that had on the upper lip, and when I performed the cytology, I saw this combination of cells. This smear was highly cellular, with and the quality of cells were pretty good. As you can see, there are both cells. So you have the histiocytes, you have many. You can recognize because they have a large cytoplasm, and the nucleus is with a light color. And you can see a lot of lymphocytes. In this tumor, it can regress spontaneously. And what you can see are the lymphocytes that are arriving to fight these neoplastic cells. And it's the presence of these neoplastic, these lymphocytes that help the regression of the histiocytoma. That's why you cannot give a cortisone to a dog with histiocytoma. We have the tendency to put a little cream with the cortisone to help because they are ulcerated, sometimes they are itchy because infected. No, you cannot give the cortisone, otherwise it will not regress spontaneously. Most of the time, in 3 months, it regress. So why should I do surgery? Because sometimes they grow just so quickly and the owner wants that we do something, or because is in an area which is really bother the animal, like in this case, or sometime on the eyelids, is get infected, so it bothers the dog. So imagine if it's on the head and the owner has to keep the cone for three months. Sometimes it's not the case, they don't want to keep it. And if it's an older dog, it's better to remove. Or when a cytology is not conclusive, sometimes it's mixed with inflammatory cells other than lymphocytes, so you have the DAPS, so it's better to remove. Or if there are failure to resolve, so if after 3 months it's still there. For example, this animal, this dog was old, and when I did the cytology, I saw the histiocyte, but in all sample I found only this little group of histiocytes. So all the dog, not sure 100% of my cytological diagnosis, I decided to remove it. Plasmacytoma. Plasma cells are cells that are type of white blood cells. They are immune cells that they are able to produce a large amount of specific antibodies. They develop from B cells. Plasma cell tumor that interests dermatology is extramedullary plasmacytoma. They are benign. They are usually solitary, and only in 0.1% they are associated with multiple myeloma. We can see easily in American Cocker Spaniel, English Cocker Spaniel, West Island Boxer, Yorkie, and German Shepherd. Normally these are older dogs, and you can have a limbs, head, and an ear, and the diagnosis with the cytology and histology. And the treatment of choice is surgery. You have to remove this dog, this tumor. And this is how it looks at the cytology. Just to show you before, here they have this typical shape, and what helps you to recognize them is this halo, white halo that they have, which is corresponded to the Golgi apparatus. Now we can move to the epithelial tumors. Epithelial tumors are squamous cell carcinoma, follicular tumors, and glandular tumors. We cannot see all tumors today because I don't have enough time, but I will present you the most important. Squamous cell carcinoma. Squamous cell carcinoma, it's a common tumor in cats. It's mainly in older adult cats. It is associated with the UV exposure, and it has been demonstrated that the chronic sun exposure is associated to progression from actinic, which is not still a tumor, so it's reversible, to cancerous, which is irreversible changes. It is the white cat on the glabrous area, they are predisposed, so that's why we find often on the nasal planum, ears, and eyelid. They are often focal, but if they are white, they can have on the nose and also on the ear. So we will see after in a case. You can see in the beginning erythema and a little desquamation when it's actinic, and then when it's moved to cancer, you can see plaque, crust, erosion, and ulcers. The diagnosis with the cytological examination we can be useful. You can see the cluster of epithelial atypic cells, and then histology is what give you the definitive diagnosis. You need to do the clinical staging, so this is based on the tumor node metastasis system, and they are actually very aggressive locally. But metastases are rare, and when they are present, they are in lymph node and lung. The treatment is depending on the clinical staging, local aggressiveness, but I would say mostly about the location and the strength of the lesions. Prevention is indispensable. So these are white cats. They are not protected, so the skin is exposed to sun. So during summer, you should add or a screen, a total screen, sunscreen, or a body against the UV. This is a case. This is a only 2-year Norwegian cat. It was a Maine Coon, which lived outdoor most of the time, and since 2 months it presents ulceration of the upper right eyelid. It was clear that something was eating the upper eyelid of this cat. So we decided to do the surgery, removing the majority of this tumor, and before this we want to be sure that he didn't have metastasis. That's why we did the RX of the lung. And here we did a very nice surgical technique. We use this technique that is reported in an article where you do the lip commissure and eyelid transposition. So briefly, they take this part and they will put there to fill the gap, because you want to remove at least 1 centimeter around the ulcer. And this is the result, so not very nice in the beginning. Also, this owner was really attentive to, he really wanted a very good aesthetical result. And since this was after 2 months, so there was still a little bit of ulceration, a little bit of loss of tissue, but in general he was healing pretty well. We did anyway the histology of this mass that we remove, that confirmed the presence of squamous cell carcinoma. And here is the cat after 1 month again. As you can see, he's healing. And here is after 2 months. So we didn't have big scars, so as you can see there is hair everywhere. But what we noticed after 3 months was the relapse here. And also he had a lesion on the nose. So here my colleague did the electrochemio, and as you can see, the electric chemio can cause also the death of the tissue, and here is the healing over time. However, once he was okay for the nose and for the eyes, he developed the problem on the ears. At this point, the owner preferred a different approach. So what we decided to do was, since the extension was pretty, here it interests half of the pinna, and in the other ear was just on the top, but this owner really wanted a very aesthetical result. So I decided to do the laser, and so I cut Probably this is a video. Let's see if it works. No, unfortunately, it doesn't work. I don't know why. Anyway, I cut the ears, and here is the result. So after having cut the ears with the laser, which is a good option because you have not the bleeding. So then I put anyway the stitches because you have a cartilage which is exposed, and I did the two sides, and here was the result. So I gave quite a bilateral good shape of the ears, and this is 5 months later. So now the cat is fine, but yes, he underwent several surgery. There are other options for squamous cell carcinoma. As we could see now, there is the electrochemotherapy, and there is also possibility to use the cryotherapy. I have both. I prefer laser because with the one treatment you remove the tumor. But if you don't have it, because it's very expensive, the CO2 laser is almost about, at least in Europe, 40,000 euro. In our clinic, they use a revolve for dentistry, so I use when it's available. But another option is to buy the CryoPen. CryoPen is about 1,000 of euro, and you can do the same. The only thing is that you have to repeat the treatment after 3-4 weeks to be sure to remove enough layer of cells to avoid relapse. This is a case to show you. I think, yeah, this is a Sphinx, was a 6-year-old. It was indoor-outdoor cats, and he lives with other cats. He came to me because he had a small spot on the skin. It was not itchy, but he was full of these little crusts, as you can see. So this was an erosive ulcerative and crusty dermatitis with a symmetrical distribution, but affecting only the non-pigmented areas. We did the cytology was full of bacteria, so I gave 2 weeks of antibiotics, but then the lesion was still there, so I took the biopsy, and the result was squamous cell carcinoma. So again, I did the lymph node cytology, the chest X-ray, abdominal ultrasound, everything was fine. So how can we treat a generalized carcinoma? So we use again the laser, and then after the laser I gave the anti-inflammatory because we use it in a very large part of the body. But in this case, we use another type of technique. So instead of cutting, we actually burn all the lesions, and with this nice tip, it's easy to do it. Yeah, for sure this video is not working. Ah, yeah. Here you can see how easy it is. You do like that on all lesion. Then I don't know if here I'm doing. Okay, then you have really to wet the lesion because you don't want the carbonization, which if the skin is too hot, you risk collateral damage. So you have to use fresh water, cold water to remove this side effect. And then you can do on a whole body, as you can see. And if you give a good anti-inflammatory drugs after, or also gabapentin, the cat has no pain after all. I will show you. So it's pretty easy. It's also nice to do it. There is you don't need a lot of experience to do this. Okay, so after 2 weeks post laser, the cat was fine. He had a good healing. There were still some scars, and so we decided to start the treatment with the Iniquimod cream. So we use Aldara 5%. What we suggest is to apply the cream only in a small area for the first weeks, because sometimes it can be can give erythema. It can be it can have a secondary effect. And also, Aldara sometimes can cause anorexia, vomit, diarrhea, and also we ask to check the functionality of the liver, because sometimes also of the kidney, because it can have also an increase of transaminases and also urea and crea. This is the cat after 2 weeks, and as you can see, is improving. Now it looks fine, but after 1 month, we noticed that there were still few lesions. These are new lesions on the head, and so we decided to do a second laser treatment. So here is the second treatment is similar to what I already showed. It's very important that you protect your eyes and also the eyes of the animals, because the laser can be dangerous for this, and also the people that are helping you. Voilà. So here is just what I was saying about Iniquimod. In this study, there were side effects associated to the use of this. So in 41%, so it had erythema, increased liver enzyme, neutropenia, and partial anorexia and vomiting. So it is very important that if you prescribe this cream, you have to follow the animal. And something about this another type of tumor, which is the multicentrical squamous cell carcinoma in situ. It's also called flying bovinoid in situ carcinoma. It's uncommon. This is a pre-malignant neoplasia, and they think that it can be caused by papillomavirus, because the papillomavirus was found in the skin of affected cats, and this is not associated to sun exposure. So they are both carcinoma, but is not associated to sun, so it can be present also in pigmented skin. They can cause multiple lesions. You have scale, crusted plaque, and the lesions are superficial and they are just in epidermis. Chronic lesion with the time can be ulcerated. Again, diagnosed with histology, but please shave the animals, because they are multicentric and you will have also in other parts of the body. And if you decide to do what I showed before, also for this type of tumor, you need to be sure that you are not missing lesion. I put this, it's not a very high quality of a journal, but I found this so helpful the first time that I did the laser, because they give you the first setting, they show you how to do it, how to manage, so you can find easily in internet this one. Glandular tumor, let's talk about sebaceous adenoma. We have also sebaceous hyperplasia. You can find the mini schnauzer, beagles, poodle, cocker spaniel. You can find easily in the limb, trunk, and eyelid, and mostly when they are getting old. The treatment of choice is, normally you can leave it, they are benign, but if they are in an area where bother the animal, you can do all the cryotherapy or laser or surgery. So I do this when or they ulcerate easily, or they bother the animal, or sometimes when they bother the owner. Here, unfortunately, it's just a partial video, but I want just to show you when I would do a cryotherapy. I would do, for example, for this small nodule, you can easily cut, but you can cut with anesthesia. If you have a cryotherapy, you can do without do the anesthesia, and you just freeze the nodule. So cryotherapy means that you use azote and you freeze the nodules, and freezing the twining 3 times, it causes the death of the cells. And after 2 weeks, you have so the owner leaves your clinic that is still, the dog leaves the clinic that still have the nodules, but 2 weeks later he will develop a crassa and the nodule will fall. And here is another video. Poor dog, he was scared. Sometimes you can also do the local anesthesia, but honestly, the lidocaine injected is more painful than what really does this technique. First, you have to clean, you have to remove the fat, the greasy layer around, so the cryotherapy will be more effective. And then you just freeze them. So with this, I have this cryopen is very easy to be precise, as you can see. The time of application is depending on the size of the nodule. You have to be sure that you congelate everything. And then you wait that there's defrosting, and then you will repeat again. A small nodule, like less than 3 millimeters, you can even do just once and it will be more than enough. Voila. I use if the size of the tumor is maximum 1 centimeter. I have better results. Or for example, in this case, is more than 2 centimeter, but the base of the tumor is very small, so I try to congelate really the base. When they are too big, I prefer the laser. And here is a nice article that shows where you can use cryotherapy for treating benign skin tumors. I try a lot of cryotherapy, also in malignant. I have a less good result. I have the tendency to say that it is not effective on malignant. The only malignant tumor that you can use with success the cryotherapy is the squamous cell carcinoma. That is okay. Mesenchymal tumor. Lipoma. So lipoma is common in dogs, is uncommon in cats. I think I've never seen cats. It's a benign neoplasm which is arise from subcutaneous lymphocytes, or adipocytes. The clinical feature is a nodule that is dome shaped or pedunculated, is well circumscribed, is very soft and flabby. It can be small or even huge. We see this in older dogs. They are popping up with the age, so when they are old, we see several of these in animals. Siamese seem to be predisposed, and in dogs, obese female dogs, and cocker, Dutch Hound, Weimaraner, Doberman, and so on. Here is an example of how they look. They can be big, they can be also bigger, normally are on the trunk, but sometimes can be huge, because anyway we have the tendency to say, well, they are benign, don't touch it. But even if it's benign, if it's in an area that can, you have to think that if it's benign at 4 years, it can be that when the dog will be 8, 10, it will be huge, this mass. So all the time think if it's anyway the case to remove, or to think the first day that he will have an anesthesia, maybe it's better to remove it. There are indeed infiltrative lipomas, which are uncommon, and these are for middle-aged animal, more in female, in Doberman Pinscher, Labrador Retriever, and you can find an extremity, thorax and neck. They are large, they are poorly circumscribed, they are soft, and they are in deep subcutaneous mass. They can infiltrate adjacent muscle and everything that is behind. Look here, how infiltrative is it. It's a problem because yes, it's benign, but it's give mechanical interference and most of the time pain because it compresses nerves. Diagnosis is cytology. You can see already before to stain this that is just fat, because also on the slide you see all the bubble of the fat, and when you color you can see the adipocytes. Histology is also present all this fat in the subcutaneous layer. Treatment. As I said, most of the lipomas they don't need treatment. So surgical only, surgical excision only if they cause pain, or for example if they are in the axilla and they cause physical impediment. Infiltrative lipoma, all the time remove. And then I found this nice article. They did the liposuction on the big lipomas. And this was a kind of nice technique. They first remove all the fat, but this lipoma, most of the time, they have a capsule. So remember, in case you will do, to remove the capsule, otherwise it will reform in very short time. Melanocytic tumor, melanocytoma. This is in dogs, older dogs, 9 years, no sex predisposition, but there are more often in Scottish Terrier, Airedale, Boston Terrier, Cocker Spaniel. Normally they are solitary. We have in the head, trunk, paws, and they usually well circumscribed. They can be dome-shaped and also pedunculated to papillomatous. Be careful that they are not, or is not all the time easy to distinguish between melanocytoma and melanoma. So every time that you see a lesion that can be or one or the other one, you have to do the biopsy. This was a very interesting dog. This dog had 100 of these mass. And I took, during anesthesia for another reason, I did a videotoscopy. I took, because the owner said he had seen a lot of time, so I don't want to do a biopsy for that. But during the videotoscopy, I took 4 samples. I had 2 melanoma and 2 melanocytoma. And I took really without even thinking these 4 lesions, so they were similar, but 2 were melanocytoma and 2 were melanoma. Cats, they are also old, there is no sex or predisposition, usually solitary, head and neck, they are also well circumscribed. Diagnosis, as I can see, it's easy. When you take the cytology, you will find these cells that are very pigmented, and you can see also in histology, and the treatment is surgery. Less than 10% they can have aggressive metastasis behavior in dogs. Other option is a laser CO2, but I don't like, because when you just burn it, you cannot do the histology after that. Cryotherapy is also reported, and you can also use imiquimod cream, but my advice is just remove it. Melanoma is the malignant one. There is no sex predisposition. We have in all the animals. The breed and risk is similar to melanocytoma, and they are often solitary. We can have in the head, limbs, digits, scrotum, lips and trunk, and they are variably circumscribed, and they are normally dome-shaped, and they can also have different color. Not all the time they are colored. Not all the time they are black. They can be also gray or brown. In cats, also all the cats, head and neck, usually solitary, and they are brown to black in color. So important when you do the histology, it's important to do it because you have to confirm the melanocytic origin. There are histological criteria. They will see if there are a lot of atypia, if there are mitosis, And then if it's amelanotic or poorly differentiated, it's important that your pathologist will suggest you the immunohistochemistry to understand if it presents these immune markers so that you can confirm it's melanoma. Then you can also use other molecular parameter. For example, the Ki67, this is your pathologist that should give you because of biological behavior. Then you can do the radical surgery excision. You can, if you remove it depends of the grade, but sometimes you can have just 4.5 months of survival time. Therapy, there are several therapies that have been tested. They use the mitoxantrone, the anti-COS2, intravenous carboplatin, and then there are also the vaccine. Vaccine is normally used for oral melanoma, not really for the melanoma of the skin. Here is an example of melanoma, and here is the cytology. Here is my case. I saw this case 6 or 7 months ago. It's a sphinx, and the owner arrived with this nodule. So honestly, it was looking not aggressive. It was very well delimited, as you can see. And when I performed the cytology, I understood already that was of melanocytic origin, but I didn't see a lot of mitosis, so I thought it can be just a melanocytoma. But I removed it. It was already quite big. It was more than 1 centimeter, so I removed it, and it was melanoma. And unfortunately, even if I cut 3 millimeters for each size, the melanoma reached the edge. So at this point, I said, what can I do? So what I did is first to repeat the second, before repeating the second surgery, I want to be sure, since it's a malignant, that we don't have already metastasis. So we did the thoracic radiography, which were clean, and also the ultrasound, the abdominal ultrasound, which was also clean. We did a second surgery, we removed the margins, and we didn't need other therapy. Thank you very much.
Deen tanarina kana Next, we are going to present Bharatanatyam. Bharatanatyam is a classical dance form of South India said to have originated in Tanjavur of Tamil Nadu. It was known as Dasiyatam since it used to be performed by Devadasis or temple dancers in the temples of Tamil Nadu long ago. The name Bharatanatyam is derived from three basic concepts of bhava, expression, raga, melody, and tala, rhythm. The dance is performed on the stage as nrittam, nrityam, and natyam. A Bharatanatyam performance starts with the prayers to God, Ganesha, and the worship of Nataraja Murti, or the dancing incarnation of Lord Shiva. The music of Bharatanatyam is based on Carnatic classical music. The instruments used are veena, flute, mridangam, and violin. Bharatanatyam.
வெற்றிவேல் முருகனுக்கு அரோகரா.
அழகு தெய்வமாக வந்து பழனிமலை மீதில் நிற்போம். அழகு தெய்வமாக வந்து பழனிமலை மீதில் நிற்போம். ஆதிசக்தி என்னை தந்தவான் அசுரத்தம்மை வென்றபடி வேறும். அழகு தெய்வமாக வந்து பழனிமலை மீதில் நிற்போம். ஆதிசக்தி என்னை தந்தவான் அசுரத்தம்மை வென்றபடி வேறும். அழகு தெய்வமாக வந்து பழனிமலை மீதில் நிற்போம். ஆதிசக்தி அன்னை தந்தவான் அசுரத்தம்மை வென்றபடி வேறும். அழகு தெய்வமாக வந்து பழனிமலை மீதில் நிற்போம். ஆதிசக்தி அன்னை தந்தவான் அசுரத்தம்மை வென்றபடி வேறும். நல்ல அமுதமென்னும் தமிழில் பாடிடும் அந்த மாழவே கருணை செய்குவன். அமுதமென்னும் தமிழில் பாடிடும் அந்த மாழவே கருணை செய்குவன். அருளுகந்த குருவாம் உயர் சீலம் என்றும் அருள் சுரந்தே காக்கும் அனுகூலம். குழந்தையாக குமரனாக கோவனாடை துறவியாக. குழந்தையாக குமரனாக கோவனாடை துறவியாக. கோலம் கொள்ளும் காட்சி என்ன சொல்வேன் கலியுகத்தோடு வரதனாய் திகழ்ந்தருளும் கந்தரு கும்பிட்டெந்தன் பிணிகள் நீங்க மகிழ்வே உள்ள குமுறல் ஒன்றே நல்ல வழி செல்வே நீலமயில் மீதில் ஏறி ஆவினன் கூடியில் தோன்றும் நீலமயில் மீதில் ஏறி ஆவினன் கூடியில் தோன்றும் நிமலனா உடந்தை முருகேசன் நித்தில தொன்முருவல் வள்ளினேசன் நிமலனா உடந்தை முருகேசன் நித்தில பொன்முருவல் வள்ளினேசன் அவன் நீலந்தனில் அன்பு செய்திடும் அடிய யாரையும் காது நின்றிடும் நீலந்தனில் அன்பு செய்திடும் அடிய யாரையும் காத்து நின்றிடும் நித்திய ஜோதி வடிவமா பிரகாசம் தூரல் நெஞ்சை நீங்காதென்றும் அங்கு வாசம் நித்திய ஜோதி வடிவமா பிரகாசம் தூரல் நெஞ்சை நீங்காதென்றும் அங்கு வாசம் நித்திய ஜோதி வடிவமா பிரகாசம் தூரல் நெஞ்சை நீங்காதென்றும் அங்கு வாசம் பாவா முருகா வடிவேலழகா 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 பாவா முருகா வடிவேலழகா
വാദ്യഘോഷമുണരുകയായി അമൃതലയമായി പൊൻപിരയിൽ വാദ്യഘോഷമുണരുകയായി അമൃതലയമായി പൊൻപിരയിൽ ഏലയടയുകയായി കരളമയമായി മണ്ണിരകയിൽ പെരുമലാനാടും കരകരും പുഴയിൽ നീരാടും കരയിലെ എന്റെ
ശോഭയിൽ മുന്നിൽ വരുകയായി നിഴപൊലിയുകയായി ഉണരുകയായി
we are now going to present a short segment of Kalaripayattu. Kalaripayattu dates back to more than 2000 years and is considered as the mother of all martial arts in the world. Bodhidharma, the Buddhist monk from southern India, who founded the Shaolin temple in China in the 6th century, developed Kung Fu from Kalaripayattu, the martial art form tempered through devoted discipline and intense meditation. The real strength of Kalaripayattu lies in unarmed combat, which was found most suitable by Bodhidharma to fend off assailants without deviating from the tenets of Buddhism, which advocates ahimsa or non-violence. However, the Kalari exponents are trained in fighting with weapons also, and the weapons used are the sword, shield, dagger, spear, and short sticks. The main aim of this exclusive martial art form is to achieve complete coordination of the mind and body. The traditional training of Kalaripayattu includes specialized and indigenous medical preparations and methods of treatment, which help attain greater suppleness of the body. Kalaripayattu. Kathakali. The dance drama of Kerala from the 17th century is rooted in Hindu mythology. The themes are religious in nature and deal with events from the epics of India, Mahabharata and Ramayana, as well as the ancient scriptures known as the Puranas. The characters express themselves through hand gestures known as mudra that are common throughout much of Indian classical dance traditions. The elaborate makeup and the large and heavy costumes have much to say of the characters they portray and are instantly recognizable. The colors used in the makeup and costumes are not for mere decoration and impact, but are symbolic of the nature of the characters at play. Though the music used in Kathakali is predominantly classical, according to the Carnatic tradition, the instruments are decidedly vernacular. The use of instruments such as chanda, idakya, shuddhamaddalam and ilatalam help bring in the local flavor to this splendid art form. Next we are going to present an episode from Mahabharata, Naragasura. This episode depicts the fight between Naragasura, a demon, and Jayanthan, the son of Indra, the king of Devaloka, the abode of the gods. The demon Naragasura has a sister named Nakratundi. One day the demon Naragasura sends his sister to the abode of the gods to bring down the celestial limbs for his pleasure and satisfaction. She goes to the Devaloka, the abode of the gods, disguised as a very beautiful woman. The celestial nymphs are convinced by Nakratundi to go with her. Just then Jayanthan, the son of the king, Indra, comes into the scene, and on seeing Jayanthan, Nakratundi, who is overawed by his presence, tries to seduce him, leaving the celestial nymphs. Jayanthan refuses her advances and sees through her disguise and draws his sword and chops off her breasts and nose and ears. Naragasura, the demon, is now in a rage. As the scene unfolds, you can see what happens between Naragasura and Jayanthan.
പോവതിനായി വന്നതും ഞാനിന്നു നിന്നെ കൊണ്ടുപോവതിനായി വന്നതും ഞാനിന്നു ഞാൻ നിന്നെ പിരിഞ്ഞുടൻ പോകയില്ല കാഞ്ച നിന്നെ പിരിഞ്ഞുടൻ പോകയില്ല കാഞ്ച ചിത്രം തവദേശിതമോട്ടാലിക പത്രിഗണങ്ങൾ കൂടാകും പത്രിഗണങ്ങൾ കൂടാകും കഥനയ ഹേ ക്രമയുധ ഭൗമഗിരാവന്നൊരു നക്രതുണ്ടി എന്നറിയണമെന്നെ നക്രതുണ്ടി എന്നറിയണമെന്നെ അന്നോദാക്ഷികളെ ഹരിച്ചനി അന്നനാസികാബുധബന്ധനമിക പൂർണ്ണം ദൈവം കണ്ടുകൊള്ളുകനി പൂർണ്ണം ദൈവം കണ്ടുകൊള്ളുകനി നിർണയമതിനുണ്ടിനെ കരാളെ നിർണയമതിനുണ്ടിനെ കരാളെ
Thank you.
റെക്കോർഡിംഗ് നിർത്തണ്ട കേട്ടോ. റെക്കോർഡിംഗ്.
Okay, everyone? Video.
Recording.
So look here.